Good morning, and thank you all for joining today's press conference. My name is Rachel Reeves, and I am the Senior Vice President of Public Affairs for AHCA NCAL. And I'm pleased today to introduce today's speakers as we release the analysis conducted by CLA on the staffing mandate. First, you're going to hear from Mark Parkinson, President and CEO of AHCA NCAL, followed by Corey Rutledge, Chief Assurance Officer with CliftonLarsonAllen or CLA. And then lastly, we're going to hear from a provider, Marie Costa, the Vice President of Clinical Services with Revive Health Senior Care Management. They operate 3 facilities in Northern Nevada, 2 in Reno and 1 in Sparks. And then after we hear from Marie, we'll just wrap it up with concluding remarks, and then we'd be happy to take your questions. When we get to that Q&A portion, we'll give specific directions, but we will be using the Q&A chat feature that's on the right-hand side of your screen. Again, we'll get to that at the end of the program. But until then, I'm going to turn it over to Mark. Thanks.
Hey, thanks, Rachel. And I want to join Rachel's comments and thank all the members of the media for spending time with us this morning. And I particularly want to thank Corey and Marie for what I think will be some very insightful comments during this media availability. At the outset, I want to say that we absolutely join the administration's goals of increasing quality and increasing staffing in America's nursing homes. We're trying to do that every single day. And while we know the administration is well-intentioned with its minimum staffing proposal, unfortunately, this proposal will have disastrous results. It will not improve quality, and in fact, it will decrease access for the people that I think the administration is trying to help. So we appreciate you taking the time to hear about the results of an analysis that has just been completed that has led us to that unfortunate conclusion. I think by now we're all aware that the administration has proposed really 2 separate requirements relating to staffing. The first is an hours per patient day requirement of 0.55 hours for registered nurses and 2.45 hours for nurse aides. And the second is a 24/7 RN requirement. Unfortunately, these proposals are inherently flawed. Both are impossible to implement for 2 major reasons. The first reason is that the workforce is simply not there. We are facing an historic challenge in getting workers in nursing homes. It's always been tough to find workers, but it has never been like this, where well over 100,000 workers have simply left our profession and have not returned. To think that we could somehow get them back and then add tens and perhaps more than 100,000 of additional workers is simply not realistic. It's also not looking at the future and the future demographics that we face. All of the researchers have indicated that we're losing nurses in this country. We're not gaining them. We can't implement this policy now, and we probably can't implement it ever. The second inherent flaw in the policy is that it's not funded. Nursing homes are woefully underfunded, particularly on the Medicaid side. Multiple studies by independent researchers have demonstrated that Medicaid margins in skilled nursing facilities are negative. The administration itself admits that this would cost at least $4 billion. The CliftonLarsonAllen analysis will show that it is more than that. But whether it is $4 billion or $6 billion or $8 billion, that is money that is simply not out there. Even at the administration's number of $4 billion, that's almost $400,000 per nursing facility, and nursing facilities just don't have that money. They will not be able to implement this proposal. Now, it's not surprising that this proposal is poor in its content, and that's because the process has been poor. Every administration, including the Obama administration, has looked at the idea of minimum staffing. It's studied it, it's talked to providers, it's done an analysis, and it has then concluded that it just won't work. So no administration has done it. Unfortunately, this administration approached this in a backward manner. Instead of studying this and talking to people in the sector that actually provide care before making a decision, the administration made its decision, announced that there would be a minimum staffing policy, and then did its study, and then talked with the sector, completely backwards of what should have been done. It's not surprising that we therefore get a policy that doesn't make sense and that can't be implemented. What is a little bit surprising is that the administration's own study concluded that this would not work, or that the policy was not justified. Its own study indicated that there was no specific threshold of hours where all of a sudden quality improves or quality declines. Despite its own study saying that, the administration was stuck. It had already announced a policy, and so it has gone forward even though its own study does not back up the policy itself. We decided that we needed to have some real analysis done as to what the impact would be on providers, but really more important than that, what would the impact of this policy be on residents? So we asked CliftonLarsonAllen to do a deep dive and look at, on a very building-specific level, can buildings meet this? How short would they be of workers? And if they are short, what would the impact be on residents? I'm pleased to introduce Corey Rutledge from CliftonLarsonAllen, who unfortunately is going to give us the results which show, what we were concerned about, that this policy simply cannot be implemented. So Corey, let me turn it over to you.
Great. Thank you, Mark, and good morning, everyone. As Mark mentioned, my name is Corey Rutledge. I'm the Chief Assurance Officer at CLA. You'll see some visuals here. In this first visual, you'll see a summary of the findings and conclusions for an analysis that CLA performed. This analysis looked at the 24/7 RN requirement, as well as both the hours per resident day staffing requirements as proposed in the rule, and estimated how many additional staff would be necessary to meet the requirements. We included in our analysis the costs associated with those additional staff. And for those who are intimately familiar with this proposed rule, it's important to note that our estimates acknowledge that the proposed rule stipulates that 24/7 RN requirements would be implemented first. Therefore, when we analyze the incremental impact of the 0.55 RN hours per resident day requirement, we did assume a portion of this criteria is met by the additional 24/7 RN coverage. What we found is that nursing homes would need to hire an estimated 102,154 additional full-time employees. 80,000 of these FTEs are nurse aides, and 22,000 would need to be RNs. So the proposed mandate would cost nursing homes, as previously mentioned, about $6.8 billion per year, and that is not adjusted for inflation. We acknowledge that this estimate is higher than the $4 billion per year estimated by CMS, primarily due to the fact that the fiscal years that are reported on are not the same. So specifically, CLA used the most recently available cost reports. Some of them are 2022 cost reports, some of them are 2021 cost reports. As you might suspect, 2022 cost reports have higher wage numbers in them, and CMS's analysis only used 2021 cost reports. We also performed an analysis that removed erroneous, outlier, or missing facility level data. And while we are not sure how CMS ran its calculations exactly, we're confident in our estimates, and we're confident that they are thorough and more up to date. So as you can see, this facility level information that you're looking at here, it tells a pretty sad story, and that is that 94% of facilities currently do not meet at least one of the three requirements that Mark outlined, which are the nurse aid criteria of 2.45 hours per resident day, the 0.55 RN hours per resident day, or the 24/7 RN coverage. Looking at each requirement on its own, 80% of facilities do not meet the 24/7 RN requirement alone, and 72% do not meet the nurse aid hours per resident day requirement alone. The next slide really looks at this in a different view. And when you look at the combinations of these requirements, of the 94% of facilities, the vast majority, or 70%, which is the 36 and the 34% stacked on top of each other, they are not meeting 2 or 3 of the criteria that are required. The next slide that we'll see is really an analysis that we did specific to Medicaid. As Mark mentioned, the Medicaid funding is woefully inadequate. And so what we wanted to do is take a look at how Medicaid census impact the ability to meet the requirements. And what we observed is that nursing homes that did not meet at least one of these requirements were more likely to serve a resident population that is primarily relying on Medicaid. So for facilities that did not meet the criteria, they averaged 56% of their total days were Medicaid days. while facilities that did meet the criteria only had an average of 43% of their days being Medicaid days. So we see a high positive correlation between as Medicaid census increases, facilities are less likely to meet the criteria. On the next slide, we look at the estimated FTEs to meet the criteria. And as I mentioned, the 102,154 FTEs required. As I mentioned, 80,000 of those will be nurse aide and about 22,000 RN requirements. So, and that is the sum of the 24/7 RN as well as the hours per resident day RN. So let's take a look at cost. So the wages associated with these 102,000 FTEs comes out to about $6.8 billion per year. Again, that is in today's dollars. So as we go into the future, we would expect that annual dollar amount to increase. Nursing homes will need considerable resources to meet the requirements of this mandate, but unfortunately, as we sit here today, about 60% of the profession is currently operating in the red. Nursing homes are faced with increased operating costs while still struggling to rebuild their workforce and occupancy rates to pre-pandemic levels. So let's talk about the resident impact. If nursing homes were unable to increase their workforce, facilities will likely need to reduce their census to meet staffing mandates. Said differently, there are two ways to meet the staffing mandate. One is to increase staff, the other is to decrease the number of residents in the facility. Those are the only two levers that can be pulled. So if we can't find the additional staff, the only thing to do is discharge residents that are currently in skilled nursing facilities. And logic would tell us that those individuals don't have any better options in terms of places to go, particularly those that are Medicaid. So if we were not able to find the staff and we had to decrease census to meet the minimum thresholds, there would be 287,524 residents that would be impacted by the census reduction in order to meet these numbers. So said differently, a total of 1.1 million residents are in facilities that do not meet the right criteria. About 26% of those would have to be discharged in order to meet the staffing mandate. And with that news, I will turn it back to Mark to share some additional analysis.
Hey, thanks, Corey. I appreciate that insight. It's very worrisome. And the point that I'd like to make is this. If we had to decrease our census, if we had to tell 287,000 residents that they could no longer live there because we needed to meet the staffing requirement, that would completely change the economics of the building, and no building can survive. 60% of buildings are already operating at a loss. Most are that have a gain. It's a pretty minor margin and minor gain. If all of a sudden we had to lose roughly 25% of our population, the whole thing would collapse. And so it's not just the 287,000 folks that are at risk of displacement. It's really everybody that lives in a nursing home, with one exception, and that is that there are some very high-end nursing homes that principally take Medicare residents and private pay residents, and those folks would be fine. That's a pretty small number of people, though. The vast majority of people, the people that are impoverished, that I really think the administration wants to help the most, the people that live principally in Medicaid facilities, they are the most at risk because of this proposal. And so now to talk about a real world example of what this would actually do, we're really pleased to have Marie here to talk with us about what the impacts would be in her facilities. Marie?
Thank you, Mark, for having me. So again, my name is Marie Costa. I'm a registered nurse and a licensed nursing home administrator. Less than 2 years ago, I relocated from Washington, D.C. area to Northern Nevada to work for Revive as a vice president of clinical services. The situation here in Northern Nevada was eye-opening. The competition here is incredible. So not only we're competing with the nursing home in the area, but we are surrounded with gigafactories and retail distribution centers that offer extremely competitive wages. Then on top of that, a local hospital started hiring LPNs. And because of the pandemic, the reality is that in the last few years have been tough for long-term care workforce. So Revive is already making tough decisions. In February of 2022, as a provider that provides primarily serves Medicaid residents, we chose not to reopen a dually certified wing that serves 60 residents due to labor shortage. We are struggling to compete with other local healthcare providers and hospital networks. So we're trying to be as innovative as possible in attracting and retaining workers. But with the increased competition from local factories, distribution centers, and other healthcare providers, we're stuck. Nevada is ranked 46th when it comes to nurse staffing shortage, making it one of the top 5 worst states facing nurse staffing shortages. It demonstrates how a one-size-fits-all staffing mandate does not acknowledge the vast differences in the labor market in various parts of the country. The proposed rule have very real impacts on the people that we serve, mostly seniors. We would be very concerned about our ability to meet these requirements and keep our doors open. Our lifeline in a nursing home is our LPNs. But under this proposed rule, LPNs do not count. It is incomprehensible that the Washington bureaucrats do not recognize the necessary role they play as part of the care team. LPNs matter. Nursing homes thrive because of the LPNs. And if LPN hours do not count, then we really have no recourse. A large portion of our residents rely on Medicaid. With this staffing mandate, especially given that it's unfunded, we simply do not have the means or the resources to attract the right people to work in our centers. Meeting the mandates, it's not just complicated, it's impossible. Just like we witness our closed wing, our centers will have no choice but to further limit admissions. At this pace, nursing homes could start closing their doors and leave our seniors without care they need. I agree with Mark. We'd love to hire more nurses and CNAs, but we need resources and programs to build a pipeline of caregivers. Immigration is a vital piece. There are thousands of nurses who are eager to come to the United States to work for healthcare. I know because I am one of them. I was given a chance to come to the United States from the Philippines to work as a nurse. I received my green card through an employment at a Maryland nursing home in the 90s. And we are doing the same thing here in Northern Nevada. We are sponsoring nurses from the Philippines to come to the United States. So for me, immigration is such an important piece in resolving our workforce crisis. But immigration is not a silver bullet. We need a comprehensive approach to recruiting and retaining more caregivers to long-term care. It starts with properly funding nursing homes so they can offer competitive wages. I hope the Biden administration will consider this impossible standard and focus on more productive ways to support our seniors. Thank you. Back to you, Mark.
Hey, thanks, Marie. Really appreciate your comments. And I'll just have a few closing comments, and then we're happy to take any questions that we might have from the media. I would say, first of all, that unfortunately, Corey's analysis and the CliftonLarsonAllen analysis confirm what we have thought, which is that virtually every facility in the country will be out of compliance. And even facilities that are not chronically out of compliance because of their Medicare and private pay population, because the enforcement period is so short, if you have a single call off on a single shift at night, you're out of compliance. At some point or another, virtually every facility in the country will be out of compliance. The policy simply doesn't make sense and shouldn't go forward. Before we offer some suggestions, though, I would say that one of the concerns that we have is the rhetoric that is coming out of the administration. We want to have a constructive dialogue with the administration, but it's hard to do that when there continue to be implications that the 200,000 people that died in nursing homes of COVID are because of the nursing homes. That statement fails to understand the basics of COVID. COVID and the deaths that were caused by COVID occurred because, unlike all of the viruses that we had fought in history before, it was being spread by asymptomatic carriers. So asymptomatic workers and workers in general were out in the general population getting COVID and showing no symptoms of it. In the first year of the pandemic, when we had virtually no testing, almost no PPE, and of course no vaccine, what was occurring is that these asymptomatic workers were coming into buildings and unknowingly, and certainly not on purpose, spreading COVID. The result was that larger buildings were getting COVID the most, and that's because they had the most workers. They had the most number of people out in the general population, and it just became a numbers game. The more workers you had, the higher probability you had that asymptomatic workers were coming into the building and creating COVID. It's really one of the ironies of this policy is that we're being blamed for COVID, and yet if in fact there had been more workers in the first year of COVID, there would have been more COVID itself in buildings. Now, that's not a reason to not have more staff, and we're not suggesting that. We want to have more staff, but it certainly is a reason to stop blaming nursing homes for the 200,000 people that died in them. Thousands of lives were saved because of the heroic acts of people continuing to work in a very dangerous situation. When the administration talks about Wall Street greed and nursing home providers just wanting to make money, it is ignoring the fact that Wall Street is basically not involved in our sector anymore. Publicly traded companies tried in the late 90s and early 2000s, and it just didn't work. As we sit here today, there are only 2 publicly traded companies that own facilities, and combined they own less than 400 of the 15,000 plus nursing homes that are out there. When the administration blames our reliance on private equity for creating problems in nursing home, again, it's ignoring the facts. The government's own statistics indicate that private equity owns less than 5% of nursing homes. Most nursing homes are owned and operated by people like my wife and Stacy when we had just a handful of buildings back in Kansas. They're operated by people like Marie, who works in an operation that has about 3 facilities. We are not this big, greedy conglomerate of companies that are trying to provide terrible care just to make money. Really, the absolute opposite is true. Providers are, for the most part, compassionate people who are mission-driven and called to this work, and that's the reason that they take care of folks that, frankly, not a lot of other people are willing to take care of. So where do we go from here? Well, the first thing that the administration should do is simply scrap the policy. It is inherently flawed. If it is unwilling to do that, then it's going to have to make some changes that prevent the million-plus people that live in buildings from having their place of residence threatened. So, for example, they would need to allow LPNs to be counted, as Maria suggested, either in the registered nurse category or in the nurse aide category. They would need to lengthen the phase-in period to 5 years for all of the requirements so that perhaps we can have some recovery of our workforce. They would need to come up with some funding mechanism so that if we could actually somehow end up finding these workers, they could actually be paid for. And then there are all sorts of minutiae in the policy that are unfairly negative and penalizing to facilities that need to be changed. So I'll finish with the way I started, which is to say that we are genuinely interested in a dialogue with the administration on how to improve quality and how to improve staffing, but unfortunately this policy is not it, and it actually makes things worse. Again, we appreciate your time, and I'll turn it back to Rachel now to see if there are any questions.
Great. Thank you, Mark. And thank you, Corey and Marie, for your remarks as well. Again, if you have a question for any of our speakers, please use the right side panel to submit your question in writing. If you can also just quickly note which outlet you're from, that would be a huge help. And Mark, we do have a question off the bat from Bloomberg Log. They would like to know, will you pursue litigation if the proposal is finalized in the way it is now? And also, before that happens, are you working with Congress to find a different solution?
Well, right now we're working with both the administration and with Congress. So we appreciate that the administration issued this as a proposed rule and not an interim final rule. And that gives us the opportunity to talk with administration officials, for our members and providers to talk with administration officials, and hopefully either stop the policy or significantly shape it before it's finalized. So that's priority number one. In addition to that, yes, we're talking with members of Congress because organically there are members of Congress that have asked what they can do to help to try to change or stop this policy. That's our complete effort now. Our hope is that the system will work, and either through the rulemaking process or through some nudging by Congress, that this policy will either be stopped or made better. And that's all we're focused on right now.
Great. Thank you, Mark. Again, if you have a question for any of our speakers, please submit that in the right side panel chat box. Not seeing any other questions at the moment, but we'll just give folks another few seconds to type their question into that right side panel box. We have a question from Zahida at Skilled Nursing News for Mark. How else might AHCA and the Biden administration work together to get to, or at least close to, the funding level needed for the mandate? We've heard one option is to increase managed care pay to a figure higher than 70% of Medicare.
The only way to come up with this large amount of money is through the Medicaid system. When we're talking, whether we're talking the $4 billion that CMS projects or the almost $7 billion that CLA projects, there's not enough money in the Medicare system and the Medicare payments that we receive to do that. And the other challenge to trying to do it through Medicare is that the facilities that really need help with staffing are the Medicaid facilities. So it needs to be some sort of a change to Medicaid. And it would require either Congress acting, because obviously CMS cannot raise funds itself. So Congress agreeing to fund the increased cost, or CMS forcing states to pay an adequate rate in their Medicaid rate before they approve the state's Medicaid plans. So the question is, can CMS, and this is probably a legal question, can CMS force states to pay additional amounts to providers in order to meet this requirement? That's the only way that we really see that this can work, is through the Medicaid system.
Thank you, Mark. And another question for you, this time from Chase at the Epic Times. Is there an open line of communication with the Biden administration, or is the administration hesitant to take into the account the view of AHCA NCAL?
Since the rule was announced by the president, we've had a really good open dialogue with CMS and with HHS. I think the mistake that was made was that there were not discussions with us before the policy was announced. But once the policy was announced in February of 2022, we've had constant discussions and have had an opportunity to make our case. We just haven't succeeded. What we've told the administration is that they should not do this because the workers aren't there. If they decide to do it, they should fund it. They should have a long phase in. They should have a reasonable waiver. The penalty should be small. A lot of different worker categories should count. And unfortunately, none of those suggestions were incorporated into the rule. We hope to continue to have discussions with the administration during this time that the rule is proposed, and we hope to be able to make an impact, but so far we have not been able to.
Thank you, Mark. I'm not seeing any other questions in the chat. So again, if you're a reporter and you have follow-up questions for us after today's press conference, please feel free to reach out to us at ahcapressoffice@ahca.org. We'd be happy to follow up with you or connect you with the CLA folks for further questions. But with that, I think we'll wrap up for today. And I just want to, again, thanks to those who attended and thanks to our speakers. And we appreciate your time today. Thank you.